Hello, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. And I've just returned back from San Diego, where Digestive Disease Week was held this year in 2022. And I wanted to call out about 10 articles, 10 abstracts and presentations that I thought were potentially on the horizon for information for you, as well as perhaps practice changing. In my practice, I think many of these will be on the short term. First is the sensitization that FIT-positive patients should have a high rate of adenoma detection. We've seen a number of reports and recommendations from the national societies that this number, rather than the 25% blended rate, should be closer to 45%. A recent meta-analysis suggested that this number should be north of that, even in the 48 to 49%. Well, this was a study that came from the Netherlands, and they looked at high-level adenoma detectors, 383 endoscopists performing 233,000 colonoscopies. The adenoma detection rate ranged from 42 to 78%, with a median detection of 65%. And they found that the rate that they particular was driven by high-level adenoma detection, but every 1% increase in the ADR was associated with a 7% risk reduction in interval colon cancers. And in fact, they suggest the target now should be raised to 60%. So again, north of 25% for sure, but I think this is practice changing. We should be doing this anyway, but it should be an analysis that drives us to a higher level detection in ADR expectations at least. Second was the presentation on malignancies in patients who were treated with Ustekinumab. I recognize this as a human monoclonal antibody that we've used for a number of years now, and ulcerative colitis and Crohn's disease, also associated with treatment indications for psoriatic arthritis and plaque psoriasis. But this was a cohort analysis of 13 studies, long-term safety data out to 5 years in Crohn's disease, 2 years in ulcerative colitis, and 5 years in psoriasis, and 1 in psoriatic arthritis. But they were able to call out 6,700 patients that were treated with Ustekinumab. This amounted to approximately nearly 14,000 patient years, and there were no significant signals for malignancy risk. There was a slight increased risk in squamous cell type cancers as it relates to the psoriasis patients, but recognize these are patients also that are treated a lot with ultraviolet light, and they have independent risks in and of themselves. So good news as it relates to our patients with Ustekinumab, at least on the long-term basis. Third was a potentially practice changing. This really is related to a nationwide analysis of malnutrition and nutritional support in hospitalized patients with inflammatory bowel disease. They studied approximately 1.3 million patients that had Crohn's disease, and approximately 811,000 that had ulcerative colitis, and 240,000 that did not have IBD. And these are patient analyses. Then they looked at, the primary focus was for protein calorie malnutrition. And the IBD patients were 2.7 to 2.9 times more likely to have this protein calorie malnutrition. And by multivariate analysis, they were able to demonstrate that these were also patients that had higher risk of readmission, mortality, as well as longer lengths of stay and higher hospitalization costs. So perhaps practice changing, it is from my perspective, look hard at these patients when they come in with IBD at nutritional status and important nutritional assessment, and potentially assistance with dietary assistance while they're there, so you can at least get them under the auspices of that hospitalization. The next one I thought was quite interesting is it relates to the role of hepatitis surface antibody for the risk of reactivation for hepatitis B virus during the anti-TNF therapy, which we use our biologics in particular. And these are patients then that were from 19 cohort studies, 1,375 total patients, and they define reactivation by a hepatitis B surface antigen seroconversion when they were core antibody positive. And lo and behold, there were 25 cases that reactivated, but they were able to find a discriminant threshold of 100 international units per liter for the hepatitis B surface antibody titer. Only 4 cases occurred when this titer was greater than 100. So the authors recommend that we should now potentially obtain a quantitative baseline of the surface antibody level, and perhaps give them a booster if their level falls below 100, and certainly maintaining that going forward. We do not have any of the prospective data to apply this, seems to be pretty easy and relatively low risk to provide this vaccination. So in my practice, I'm going to start doing this as practice changing. The next on the practice horizon is a very exciting study looking at the safety and tolerability of a pharmacodynamic assessment of a product called KAN-101, catchy name, but nonetheless, it's a novel liver-targeted therapy to induce immunologic tolerance to gliadin in celiac disease. And so they loaded the patients up, then they gave them also 3 separate doses over the course of a week, and they challenged them with a gluten challenge for 3 days. And then they looked at gliadin-specific T-cell responses, and in fact, they found a demonstrable and very significant reduction in this intolerance thereby to the gliadin challenge. So on the horizon, at least, very promising as it relates to our patients with celiac disease. On the perhaps immediate practice changing is the waterfall study, which was basically a study in acute pancreatitis looking at a multi-centered controlled trial with aggressive versus moderate goal-directed fluid resuscitation for acute pancreatitis. We've always taught our residents to give them lots of fluid when they hit the ER. It's a retroperitoneal burn. They're fluid depleted. They need to get more fluid. And the national guidelines have suggested this as well, but there's been some challenge to that more recently. So this is a prospective study, 18 multinational centers, and they randomized to receive a lactated ringer solution, 20 ml per kilogram bolus over a 2-hour period, followed by a 3 milliliter per kilogram per hour. And this was compared then to the moderate sedation, and this was a lactated ringus bolus of 10 mLs per kilogram in the case only of hypovolemia, and no bolus in patients with normal volemia. And then they were followed by getting a maintenance dose of 1.5 ml per kilogram per hour. And the patients were assessed at 12, 24, 48, and 72 hours. And again, there was no change here in pancreatitis. There was a significant change as it relates to to fluid overload. And in particular, developing the signs of fluid overload were nearly 3 times greater in the patients with this aggressive lactated ringers resuscitation. There was no trend as it relates to organ failure or any type of peripancreatic necrosis. So again, things that we're starting to really recognize as we can give too much of a good thing with fluids. And in fact, they stopped this trial at the interim analysis, recognizing the risk. So again, take a step back on your fluids, look at goal-directed, and particularly look at their fluid volume status when they come in. Next was it relates to budesonide in microscopic colitis. This comes from Olmsted County in the group at Mayo. They found out of 450 patients with microscopic colitis that was lymphocytic or collagenous. They were finding that actually the two did have a little bit of a difference as far as the response to what I'm going to suggest, but they grouped them together for the presentation. And looking at this, they found 162 patients that were treated with budesonide. The median age was 67, and the ranges were in the 23 to 91. Predominantly women, 78% were women. And the good news was nearly 80% had a complete response, about 13.5% had a partial response, and there was no response in approximately 5%. But after induction, 63% had recurrence after discontinuation. So again, we see this in clinical practice. Approximately 28% required further budesonide induction without maintenance. But we found, at least at the study presentation, they found that 58% required long-term budesonide maintenance, and 13.5% were treated with other binders like the bile acid binder or bismuth subsalicylate. Here, the median time to recurrence after induction was 98 days. The range here was 7 to 221 days. And the budesonide maintenance, all patients responded. So once they relapsed, if they came back and they needed to be retreated, 98% of patients had complete response. But again, after discontinuation of maintenance, they tended to have a relapse. About 46% had recurrence, and budesonide was then restarted in these patients again with a very high sustained response of 88%. So the median duration here of the cumulative duration of the maintenance treatments was 62 weeks, and this ranged anywhere from 16 to 469 weeks. So extended data follow-up. There is not any data as it relates to anything that they did for an adrenal axis assessment, but there was no significant major problems that they identified. Again, using steroids, it does have implicit risk, but seemingly quite safe as it relates to extended budesonide, and certainly patients that relapse have a high rate of response. Next is a very exciting one as it relates to Dupilumab, and this is something that Dupilumab was just approved actually the same week by the FDA. It's a human monoclonal antibody that blocks the shared receptor for IL-4 and IL-13. And this is these are the key drivers for the type 2 inflammation that we see in eosinophilic esophagitis. And this is a phase 3 study that was randomizing 240 patients to 2 doses of Dupilumab and placebo. And in fact, the higher dose, the 300 milligram per week, was the dose that was most effective as it relates to targeted endpoint here of the resolution of their symptoms. The secondary outcomes included the dysphagia symptom questionnaire and their endoscopic reference score, as well as driving the eosinophil count to 6 or less than 6 or less than or equal to 6. This was accomplished about 53% in the patients that received the 300 dose weekly. The every 2-week dose seemed to be quite effective, but didn't meet the same objectives, and that's what led the FDA most recently to actually approve this. So now we have a drug that is the first approved drug for eosinophilic esophagitis. It's a subcutaneous injection, seems to be very well tolerated, and certainly the safety on it seemed to be quite good as well. So very short-term practice changing. The next was a phase 3 trial on another exciting drug as it relates to ulcerative colitis. And this is Mirikizumab, and this is a humanized IgG4 monoclonal antibody directed against the P19 subunit of IL-23. And this is a phase 3 study, so after the patients had responded, at least of those patients that had responded in the induction series, they were then re-randomized in a 2-to-1 ratio, giving a 200 milligram subcutaneous dose every 4 weeks for 40 weeks and compared to placebo. And at week 40, there was a combined clinical remission, and this included endoscopic, histologic, as well as symptom-directed analyses, approximately 50% compared to placebo, so a 25% absolute risk reduction in well-tolerated, no safety signals. So again, on the short-term horizon, a new drug for ulcerative colitis with a very good response rate, in particular once they've achieved initial remission. And the last was Vonoprazan, which is a new proton pump inhibitor, really as it relates to what's now called the potassium competitive acid blocker, or a PCAB, and there have been a number of these in evolution. This one is currently available in the US, at least as it relates to treatment of H. pylori, and this was a double-blind trial in the US and Europe with erosive esophagitis. And again, these were comparing patients at an 8-week healing phase as well as at week 24 for maintenance. And this is a dose ranging as it relates to Vonoprazan and lansoprazole. They did find that it was non-inferior to lansoprazole in mean-free heartburn days, but superior as it relates to absolute healing of esophagitis. This was across all grades of esophagitis. The relative risk reduction here as it relates to the 8-week data was approximately 7. But in particular, as it relates to the severe esophagitis, the absolute risk reduction was closer to 20%, in particular when you got to the higher dose of Vonoprazan, and that's a 20 milligram dose. Healing, again, continued in the maintenance dose as it relates to going out, and the absolute maintenance risk reduction was approximately 7 compared to the 2 doses of Vonoprazan, a little higher on the 20 milligram. But in particular in C and D, where the discriminant was closer to 14% difference compared to 20 and a little less, a little north of 12 as it relates to 12% difference as it relates to the 10 milligram dose. So interestingly, there was no difference in heartburn relief-free days despite these 2 doses and the lansoprazole. So short-term horizon, for sure we have it on the target for H. pylori, but will be likely on the short-term horizon for our patients with more severe esophagitis, which is where I really think this would really find a unique place. So lots of new data as it relates to potentially on the horizon and potentially practice changing. Hopefully these short words have given us perspective on what went on at DDW 2022. Thanks again for listening.